Endoscopy nursing, esophagogastroduodenoscopy. Scenario 1, pre-procedure orientation and anxiety relief.
Good morning, Mr. Lee. I'm Nurse Kim, and I'll be helping you get ready for your endoscopy today. How are you feeling?
Honestly, I'm not sure what to expect. They just told me to come this morning. I didn't get much explanation. Should I be wearing this? Am I supposed to take any pills?
I understand completely. It can feel a bit overwhelming. Let me walk you through everything step by step so you know exactly what's going to happen and what we'll do to keep you safe and comfortable.
That would help. I'm kind of nervous, especially about the sedation part.
That's completely normal. First, let's talk about preparation. You weren't supposed to eat or drink anything since midnight. Did you have anything this morning?
No, I followed that part. I stopped eating last night after 9 p.m. Just had a sip of water to take my blood pressure pill.
Perfect. Taking your blood pressure medication with a sip of water is allowed. You're good on that. Now about your clothing, we'll ask you to remove your jacket and any tight belts or accessories. You'll be given a hospital gown if needed, and we'll make sure you're covered and warm. Do you currently wear dentures or any removable dental appliances?
Yes, I have full upper dentures.
Thanks for letting me know. Before the procedure, we'll need to remove them to prevent any accidental injury or choking while you're sedated. I'll help you with that a little later.
I didn't know about that. No one told me. And will I be asleep the whole time?
You'll receive moderate sedation. It's designed to help you relax and reduce awareness, but you'll still be breathing on your own. Most patients say it feels like a light nap, and many don't even remember the procedure afterward.
Okay, that sounds better. I just get scared when I hear the word sedation.
Totally understandable. We'll monitor your blood pressure, oxygen, and heart rate closely the entire time. If at any point you feel uncomfortable, we're right there with you. Do you have a family member or caregiver here with you?
Yes, my daughter is outside in the waiting room.
That's great. She'll need to stay close because you won't be able to drive or go home alone after sedation. We'll give her updates when you're done, and she can accompany you during discharge.
Nurse Kim hands Mr. Lee a printed checklist and calmly literally reviews each point with him.
Nothing to eat or drink after midnight. Confirmed. Continue essential medications with minimal water. Confirmed. Remove dentures and accessories before the procedure. Expect light sedation, not general anesthesia. Need a caregiver to assist after discharge.
Thanks, Nurse Kim. That really clears things up. I was imagining all sorts of scary things. You made it sound manageable.
I'm glad to hear that. You're not alone. We're here with you every step of the way. Let's get you settled and prep your IV line next.
Scenario 2, NPO violation and IV fluid management before gastroscopy.
Mr. Lee, did you just eat something?
Yes, I thought I could have a quick bite this morning. I had half a slice of bread and a little water about an hour ago.
Okay, thank you for telling me. Just to confirm, you ate around 7:30 a.m.?
Yes, that's right. Is that a problem?
Yes, a little. For this gastroscopy, your stomach needs to be completely empty. Eating or drinking before the procedure increases your risk of aspiration. Food or liquid could go into your lungs while you're sedated. That can be very dangerous.
Oh, no, I didn't know. I thought fasting meant just skipping rice or heavy food.
I understand. It's a common misunderstanding. The instructions were to stop eating and drinking from midnight. Let me check with the doctor right now. We may need to postpone the procedure.
Nurse Kim phone SBAR to Dr. Johnson.
Hi, Dr. Johnson. This is Nurse Kim calling from the endoscopy unit. I'd like to update you on Mr. Lee, scheduled for a sedated gastroscopy this morning. He ate a piece of bread and drank some water around 7:30 a.m. He's a 67-year-old admitted for suspected gastric ulcer. His EKG and consents are completed, and sedation is planned. The patient is currently stable. I recommend postponing the procedure until after a safe NPO period is completed. Also, would you like me to initiate IV fluids in the meantime?
Yes, let's delay the procedure to the afternoon, at least 6 hours after the last oral intake. Start IV normal saline 500 milliliters at a maintenance rate. Monitor vitals every hour.
Got it, thank you, doctor. I'll update the team and educate the patient. Mr. Lee, I spoke with the doctor. Because you ate recently, we're going to safely delay the procedure until this afternoon, at least 6 hours after your last bite. We'll give you IV fluids to keep you hydrated.
I'm really sorry. I should have checked.
It's okay, it happens. What's important now is your safety. We'll start the IV, monitor your vitals, and I'll explain everything so you're more comfortable next time.
Nurse Kim prepares and starts the IV line, 22 gauge right forearm. Nurse Kim educating as she works.
This is normal saline. Just sterile water with a bit of salt to help your body stay balanced while you're fasting. You might feel a pinch. Let me know if you feel dizzy, cold, or if the site becomes painful.
Nurse Kim checking IV site, setting timer, and reassuring patient. Scenario 3, missing consent forms for sedated gastroscopy. Nurse Kim is reviewing Mr. Lee's pre-procedure checklist. The nurse notices that the sedation consent form and dental damage consent form are both missing from the file.
Mr. Lee, you're scheduled for a gastroscopy with sedation this morning, correct?
Yes, that's what they told me. I've never had one before, though.
I understand. I'm just reviewing your chart, and I noticed that a couple of important forms are missing. We need a separate sedation consent form and a dental injury consent form before we can proceed.
I already signed some papers when I was admitted. Isn't that enough?
You did sign the general procedure consent, but for sedation, we need your separate written agreement. It covers the risks of sedation like low blood pressure, slow breathing, or rare allergic reactions. The dental form is to confirm that you understand there's a small risk of tooth damage if you have dentures or loose teeth.
Oh, no one told me about that part. I do have dentures.
Thank you for letting me know. Before we start, we'll also need to remove your dentures. I'll help you with that in a moment.
Is this going to delay the procedure?
We can prepare the forms and have you review and sign them right away. I'll also need to notify the doctor that we had missing paperwork. Let me take care of that now.
Nurse Kim steps aside and calls the doctor using SBAR format. Nurse Kim phone to Dr. Park.
Hi, Dr. Park. This is Nurse Kim from the Endoscopy unit. I'm calling about Mr. Lee, scheduled for a sedated gastroscopy this morning. While checking his file, I found that the sedation consent and dental injury acknowledgement forms were missing. Mr. Lee is a 70-year-old male admitted for evaluation of chronic epigastric pain. General procedure consent was signed at admission, but not the sedation-specific ones. He has dentures in place and was unaware of the additional forms. He's alert, cooperative, and currently stable. I'll explain the documents to him, have him sign both, and proceed as scheduled. Please confirm if that's acceptable.
Yes, go ahead with the forms. Thanks for catching that. Let me know if there are any other delays.
Will do. Thank you, doctor.
Nurse Kim returns to Mr. Lee's bedside with the forms.
Mr. Lee, I've got the forms here. I'll walk you through each one. Then you can sign them when you're ready.
Nurse Kim educating while showing the forms.
This one explains the sedation process. It tells you that we'll use medications to help you relax and sleep lightly during the procedure. You may feel drowsy afterward and will need someone to accompany you home. And this form explains the possibility of minor dental injuries, especially if teeth are loose or if dentures shift during the procedure. It's rare, but we always inform patients just in case.
Okay, that makes sense. I'll sign them.
Great. I'll also go ahead and help you remove your dentures now.
Mr. Lee signs both forms. Nurse Kim removes the dentures and places them in a labeled denture container.
I've labeled your denture case with your name and room number. It'll stay here safely until the procedure is done.
Thank you for explaining everything so clearly. I feel better now.
You're very welcome. I'll finish preparing everything now and check your IV line before we move you to the endoscopy room.
Scenario 4, incomplete IV line patency check before transfer. Nurse Kim receives Mr. Lee as he's wheeled into the endoscopy room. The IV line is already connected to normal saline, but the dressing appears loose.
Welcome, Mr. Lee. I'll double-check a few things before we begin. How are you feeling?
A bit nervous, but I think I'm ready.
You're doing great. Let's take a look at your IV site before we get started.
Nurse Kim checks the IV line on the left forearm. She notices sluggish flow and mild blood backflow at the extension tubing.
Your IV line doesn't seem to be flowing properly. Did you feel any discomfort or tightness when they placed it earlier?
A little sting at the time, but nothing much after that.
All right, I'm seeing some blood reflux in the tubing, and the site feels slightly puffy. That can mean the IV isn't fully patent. It might be infiltrated or positioned incorrectly. We need a reliable IV access before giving sedation. Let me pause things and consult the doctor.
Nurse Kim SBAR to Dr. Choi.
Hi, Dr. Choi. This is Nurse Kim from the endoscopy room. I'm calling about Mr. Lee, scheduled for sedated upper endoscopy. His current IV line is showing blood reflux and poor flow. The site appears infiltrated. He's a 68-year-old inpatient admitted for melena and is due for sedated gastroscopy. IV normal saline was started from the ward 22 gauge line this morning. Site shows mild swelling with sluggish drip. Patient is stable. I recommend removing the current line and reinserting a new IV before starting the procedure. Is that okay?
Yes, go ahead and place a new line. Let me know once it's secured.
Will do. Thank you, doctor. Mr. Lee, I spoke with the doctor. We'll place a new IV in your other arm to make sure everything flows well during the procedure. It's a quick step and I'll monitor closely.
Okay, thank you for catching that. I didn't even notice anything was wrong.
That's exactly why we double-check everything. You're in safe hands.
Nurse Kim removes the faulty line and reinserts a new 22 gauge IV in the right forearm. Flushes with normal saline to confirm patency. Dressing applied securely. Nurse Kim finishes the check and signals the team that Mr. Lee is now ready for sedation. Scenario 5. Patient arrives wearing dentures before gastroscopy. Mr. Lee walks into the endoscopy room accompanied by a staff member. Nurse Kim notices that he is still wearing his upper dentures.
Good morning, Mr. Lee. I see you're all checked in and ready for your procedure. Let's do a few final checks before we begin.
She glances at his mouth and notices the dentures.
Oh, I see you still have your dentures in. Do you mind if I help you take those out now?
Oh, should I take them out? No one mentioned that. They feel fine.
Yes, we always remove dentures before sedation. Even though they feel comfortable, they can loosen during the procedure, especially when you're relaxed under sedation. If the dentures shift unexpectedly, there's a risk of airway blockage or even aspiration. That's something we want to avoid at all costs.
I didn't realize it could be that serious.
Absolutely. It's a safety issue, not just a comfort one. Also, if you keep them in, there's a small chance they could chip or crack during scope insertion.
Okay, I guess it's better to be safe.
Thank you for understanding. I'll give you a labeled container where we'll store your dentures securely. We'll return them to you right after the procedure is done.
Nurse Kim assists Mr. Lee in removing his upper dentures and places them in a clean, labeled denture case with his name and room number.
Here we go. Your denture case is right here, and I've labeled it with your information. It'll stay with us in the procedure room.
Thank you, Nurse Kim. I was a bit embarrassed to ask earlier.
Please don't ever hesitate to ask. A lot of people forget or feel unsure. It's part of my job to keep you safe and informed.
Scenario 6, incorrect test order, upper endoscopy before abdominal ultrasound. Mr. Lee has just returned to the recovery bay after his sedated upper endoscopy. Nurse Kim enters to check on him and sees a transport order for abdominal ultrasound.
Hi, Mr. Lee, welcome back. You did very well during your gastroscopy. Are you feeling okay?
A bit bloated, but I feel okay. They told me I'm heading to ultrasound next?
Let me just confirm that.
Nurse Kim checks the electronic order and notices abdominal ultrasound is scheduled immediately after endoscopy.
It looks like the abdominal ultrasound was supposed to be done today as well. Did anyone tell you which test would come first?
No, they just said I'd be getting both sometime today. No one explained the order.
All right. Thanks for letting me know. Actually, we usually perform the abdominal ultrasound before the endoscopy. During gastroscopy, we inflate the stomach with air to get a clear view, and that gas can interfere with the ultrasound images, especially in the upper abdomen. Doing the ultrasound now may lead to unclear or invalid results. Let me notify the doctor and clarify if we need to reschedule it.
Nurse Kim SBAR call to Dr. Han.
Hello, Dr. Han. This is Nurse Kim from the endoscopy recovery area. I'd like to update you about Mr. Lee, who just completed his upper endoscopy. The patient is now scheduled for an abdominal ultrasound immediately post-endoscopy. He's a 66-year-old inpatient with chronic abdominal discomfort. Both upper endoscopy and ultrasound were planned for today. Gastroscopy was performed first, and air insufflation was used during the procedure. Patient is stable but mildly bloated. I recommend postponing the ultrasound to tomorrow or later today after gas absorption, or consider reordering the scan with radiology.
Yes, please postpone the ultrasound. Let's avoid repeating it unnecessarily. Thanks for catching that.
Will do. Thank you, doctor. Mr. Lee, I spoke with your doctor. We'll delay the ultrasound for now so we can get the best quality images. It's because of the air we introduced during the endoscopy, it can distort the ultrasound results. We'll either reschedule it for later today or tomorrow when the gas has clear.
Oh, that makes sense. I was wondering why I felt so full.
Yes, it's a normal side effect. We'll give you a warm bag for the bloating and keep you comfortable in the meantime.
Scenario 7, patient complains of abdominal bloating and pain immediately after the procedure. Mr. Lee is lying on the bed in the recovery room, holding his abdomen with a tense expression.
Nurse, my stomach feels really bloated and painful. Is this normal?
Nurse Kim approaches calmly literally and speaks reassuringly.
Can you tell me exactly where and how bad the discomfort is? Did the pain start suddenly?
It's just this intense bloating. It feels like my stomach is being stretched. Is something wrong?
I understand, Mr. Lee. What you're feeling is actually quite common. During the endoscopy, air was introduced into your stomach to get a better view. That can cause temporary bloating and discomfort afterward. Many patients feel the same way. It should get better as the air passes naturally.
Oh, I see. I was really worried.
You don't need to worry. Let's apply a warm pack to your abdomen. That usually helps relieve the discomfort.
Nurse Kim prepares a microwavable warm pack and gently places it on Mr. Lee's abdomen.
I'm placing this warm pack on your stomach. It should feel more comfortable in about 10 minutes. If you feel dizzy, sweaty, or if the pain gets worse, let me know right away.
Okay, thank you. I feel more at ease now.
Nurse Kim checks his vital signs.
Are you feeling any better now?
Yes, definitely. The warmth is really helping.
That's great to hear. As the gas passes, you'll feel even more relief. Just try to relax and rest for now, okay?
Scenario 8, suspected bleeding after biopsy during endoscopy. Mr. Lee is seated upright in the recovery area, holding a tissue with light blood streaks.
Nurse, I just spit into this tissue and there's some blood in it. Is that normal?
Nurse Kim walks over and calmly literally observes the tissue.
Let me take a look, Mr. Lee. I see a small amount of blood mixed with saliva. Did you have a biopsy during your endoscopy?
I think the doctor mentioned taking a small sample. Is this bleeding dangerous?
It's not uncommon to have minor bleeding after a biopsy. What you're seeing now is usually a small amount and expected. However, I'll need to monitor you closely and check if there's any ongoing bleeding or other symptoms.
I don't feel dizzy or anything, just a bit anxious.
That's completely understandable. I'll also inform Dr. Han right away so we can reassess you together.
Nurse Kim checks vital signs, within normal range. Nurse Kim contacts Dr. Han via phone.
Hello, Dr. Han. This is Nurse Kim in the recovery area. Mr. Lee, the patient who underwent an upper GI endoscopy with biopsy, is spitting out small amounts of blood mixed with saliva. Vital signs are stable. No signs of dizziness or severe discomfort. Would you like to come assess him?
Yes, I'll be there shortly. Please keep him in a semi-Fowler's position and monitor for further bleeding.
Dr. Han arrives and examines the patient.
Good morning, Mr. Lee. I see a bit of blood, but it appears mild. Let's keep you under observation for a little longer. If it increases or if you feel dizzy, let us know right away.
Thank you, doctor. That's reassuring.
Scenario 9, Post-Endoscopic Variceal Ligation Nursing Situation. Mr. Lee is lying in bed, holding his throat and wincing slightly.
Nurse Kim, my throat hurts and I feel some pain here in my belly too.
Nurse Kim approaches and checks the patient's general condition.
Let me take a look, Mr. Lee. A sore throat is common after an EVL procedure. You had a band placed on a varix today, correct?
Yes, that's what the doctor said. But the abdominal pain feels kind of heavy.
I understand. Let me check your vital signs first.
Vital signs are checked. Stable.
Your vital signs look stable. A mild sore throat and some abdominal discomfort are typical after this procedure. However, I'll monitor you closely for any signs of bleeding or worsening pain. Have you experienced dizziness, black stool, or vomiting?
No, none of that. Just the soreness and stomach pain.
All right, that's reassuring. But if you experience tarry stools, vomiting blood, or severe abdominal pain, please let me or the doctor know immediately.
Nurse Kim calls Dr. Han to report and confirm status.
Dr. Han, this is Nurse Kim in recovery. Mr. Lee, the EVL patient, is reporting mild sore throat and moderate abdominal discomfort. Vitals are stable. No signs of active bleeding.
Thanks. That sounds within expected limits. Please continue monitoring. If symptoms escalate or any bleeding signs appear, notify me right away.
Mr. Lee, I've updated Dr. Han. Everything looks fine for now. Try to rest, and I'll keep checking on you. If you notice anything unusual, press the call button right away.
All right. Thank you, nurse.
Scenario 10, Confusion regarding resumption of diet after endoscopy.
Nurse Kim, can I get some rice porridge now? I haven't eaten all morning.
I understand you must be very hungry, Mr. Lee, but we need to wait a little longer before you can eat.
Why? The test is done, isn't it? I'm feeling fine now.
Yes, the procedure went smoothly, but we need to wait for Dr. Han to interpret the results. Also, we have to confirm your diet order first. Some findings might require continued fasting or diet modification.
Oh, I didn't know that. I thought I could eat right after the test.
That's a common misunderstanding. It's very important to wait until your digestive system is fully safe to resume eating. I'll check your chart and contact Dr. Han for confirmation.
Nurse Kim checks the EMR and finds no diet order yet.
There's no diet order entered yet. I'll give Dr. Han a quick call now.
Calls doctor on the ward phone.
Dr. Han, this is Nurse Kim from the endoscopy unit. Mr. Lee, who just completed the upper endoscopy, is asking to eat. There's no current diet order. Could you please advise?
Please keep him NPO until I finish reviewing the images. I'll enter a diet order shortly.
Understood. Thank you, Doctor. Thank you for waiting, Mr. Lee. Dr. Hannes reviewing your results now and will enter a diet order soon. Until then, please refrain from eating or drinking.
Okay, thanks for letting me know.
Endoscopy nursing, colonoscopy care. Scenario 1. Patient arrives with inadequate bowel prep, colonoscopy postponed for safety reasons. 8:15 a.m., pre-procedure bay.
Mr. Jenkins, good morning. I'm Nurse Kim, and I'll be helping you get ready for your colonoscopy today. How are you feeling this morning?
Morning, nurse. I'm all right, I guess a little nervous, to be honest. I've never had anything like this before.
That's completely understandable. It's totally normal to feel that way, especially for your first time. I'll walk you through every step and make sure you're comfortable. Can I just confirm your name and date of birth?
Thomas Jenkins, June 12, 1959.
Thank you. Now, let's talk about your bowel preparation. Did you take all the prep solution as instructed?
Yes, I followed the instructions. I started at 6 p.m. last night and had the second dose around 5 this morning. But I still feel kind of bloated. And the last time I went, the stool wasn't really clear. More like murky brown water.
Thank you for telling me. That's actually really important. The goal of the prep is to have light yellow, almost clear liquid stool, like diluted lemonade. That ensures the doctor has a clear view during the exam. If there's still residue, it can block the camera and increase the risk of missing something important.
Oh, I didn't realize it had to be that clear. I thought just going to the bathroom a lot was enough. I went at least 6 times.
Yes, that's a good start. But it's also about the quality of the output. Let me ask, did you feel nauseated or have trouble finishing the solution?
Honestly, yeah, the taste was awful. After a while, I felt like gagging, and I think I didn't drink as much of the second bottle as I was supposed to.
Thank you for being honest. That actually helps me understand the full picture. In that case, your bowel may not be fully prepared. Let me check with the doctor and see how we'll proceed. We may need to delay the procedure and give you an extra round of prep.
Oh, really? That's disappointing. I took a day off work for this, and my daughter drove me in early this morning.
I completely understand how frustrating that is, especially with all the planning involved. But trying to do the procedure now without full visibility might mean we miss something, or worse, have to repeat the entire exam. That's not something we want to put you through.
Yeah, makes sense, I guess. I just hate the idea of drinking more of that stuff.
I hear you. Let me share a few tips that can help. Try chilling it in the fridge. Cold prep is easier to drink. Also, using a straw and sipping slowly can help with the taste. And if you feel bloated or gassy, walking around helps your system move better.
Nurse Kim on the phone with Dr. Patel.
Hi, Dr. Patel. This is Nurse Kim calling from Endoscopy Bay 3. I'm calling about Mr. Thomas Jenkins, who's scheduled for colonoscopy this morning. He reports inadequate bowel prep. He's a 65-year-old male, first-time screening, family history of colon cancer. He started PEG at 6 p.m. and attempted the second dose at 5 a.m. but couldn't finish it fully. His last output was brown liquid, not clear yellow. The patient is alert and stable. He reports bloating, no nausea or pain, but based on stool description and incomplete second dose, the bowel is likely not adequately prepped. Recommend delaying the procedure and starting an additional 1-liter PEG solution over 2 hours. We can rebook for tomorrow morning if that's acceptable.
I agree. Delay the colonoscopy, administer the additional 1-liter PEG, monitor hydration, and reschedule for 8:30 tomorrow.
Understood, doctor. I'll take care of it. Mr. Jenkins, I spoke with the doctor. We're going to hold off on the procedure today and give you an additional round of prep, 1 liter over 2 hours. Then we'll reassess. We've rescheduled you for tomorrow morning at 8:30.
Okay, thank you for explaining everything clearly. I still feel annoyed, but at least I know what's happening.
That's totally fair. Let's make tomorrow as easy as possible. I'll be checking on you while you're taking the prep. Just let me or any of the nurses know if you feel nauseated or dizzy at any point.
All right. I appreciate you taking the time to explain all this. You've been really patient with me.
It's my job, and I'm glad to support you through this. You're doing great.
Scenario 2, patient develops vomiting and bloating during laxative intake. Nurse provides symptom management, education, and emotional support.
Mrs. Park, good evening. I'm Nurse Kim, your evening nurse. How are you feeling?
Oh, nurse, not so good, honestly. I started drinking that solution you gave me, and now I feel awful. I think I only managed to get through half of it. My stomach is so full, I feel like I might burst. And I vomited a little while ago. It was terrible.
I'm really sorry to hear that. That must have been very uncomfortable. Let me help. You're doing an important job preparing for your colonoscopy, but sometimes the prep can be hard on the stomach. You're not alone in this. Can you tell me exactly when you started drinking the solution?
Around 5:30, I started slowly, like the instruction sheet said. I drank about 250 milliliters every 15 to 20 minutes. It was going okay at first, but after the second cup, I started feeling really full and nauseated. I pushed through for a bit, but then around the third cup, I just couldn't anymore. I vomited right after that. Maybe I only drank 700 milliliters in total.
That's really helpful to know. You were doing your best, and I appreciate how closely you tried to follow the instructions. When you vomited, did you notice anything unusual? Any blood or odd color?
No blood, just clear liquid, mostly the prep. It didn't even feel like I digested anything. It came up pretty quickly.
Okay, that's reassuring in some ways. It sounds like your stomach may have reached its limit with the volume and taste. Did you have any abdominal cramping, sharp pain, or just the bloated feeling?
Mostly bloated, like there's a balloon in there. I feel so uncomfortable, like I can't move freely. And I'm a bit lightheaded, too.
All right, thank you. I'll check your vital signs and gently assess your abdomen. If you're showing signs of dehydration, or if your body isn't tolerating the prep, we'll pause it and switch to IV hydration. There are also medications we can give for nausea.
Nurse Kim begins physical assessment. She palpates the abdomen.
I'm going to gently press on your abdomen now. Please tell me if anything feels painful or different.
It's not painful, just feels tight and full.
Nurse Kim checks vital signs.
Your blood pressure is a bit low and your heart rate is elevated, which suggests you might be mildly dehydrated. Combined with the vomiting and bloating, I think we should stop the bowel prep for now and focus on relieving your symptoms. I'm going to contact Dr. Chen and explain everything. Once we get approval, we'll start IV fluids and give you something to help with the nausea.
Does this mean the colonoscopy will be canceled?
Not necessarily. Many patients have temporary issues during the prep. With proper symptom management and some extra time, we can often resume once your body feels better. Our goal is to make sure you're safe and comfortable while getting you ready.
I really don't want to go through this again. That drink is awful. I was trying so hard.
And I see that, I truly do. You're doing your best, and that matters. The prep is challenging for a lot of people. You're not alone in this. We can give you some tips to make it easier when we restart, like chilling the solution, drinking it with a straw, or sucking on lemon candy in between.
I wish someone had told me that earlier.
You're right, and I'm sorry we didn't explain that in advance. Let's make sure from now on you get every bit of support. For now, let me step out and speak with the doctor. I'll be back shortly.
Nurse Kim makes phone call using SBAR.
Hi, Dr. Chen. This is Nurse Kim from 6B. I'm calling regarding Mr. Linda Park in room 612, scheduled for a colonoscopy tomorrow morning. The patient vomited after ingesting about 700 milliliters of PEG solution. She reports abdominal bloating, nausea, and lightheadedness. 62-year-old with history of diverticulosis. No known allergies. You ordered 2-liter PEG over 3 hours. No premedication for nausea. Abdomen is distended but soft. No guarding or tenderness. Suspected mild dehydration. Recommend holding PrEP, initiating IV fluids, and administering antiemetics. Would you prefer ondansetron IV?
Yes, hold the PrEP. Start 500 milliliter of 0.9% normal saline over 1 hour. Give IV ondansetron 4 milligram now. Reassess in 2 hours. If her symptoms improve, resume PrEP slowly with smaller sips.
Understood. I'll initiate the orders and monitor closely. Mrs. Park, I've spoken to Dr. Chen. We're going to stop the PrEP for now. I'll start an IV to help rehydrate you and give you an anti-nausea medication. We'll reassess how you're doing in about 2 hours. If you're feeling better, we may try resuming the PrEP slowly, in smaller sips.
Thank you. I was really starting to panic.
You're doing great. It's okay to feel overwhelmed. This process is hard for many patients, especially when you're already tired and stressed. I'll stay close and check on you regularly.
What happens if I can't finish the PrEP at all?
That's something we would discuss with the doctor. Sometimes we can use alternative methods or postpone the procedure until your body is ready. But we're not there yet. For now, we'll focus on making you comfortable and helping your body tolerate the PrEP, one step at a time.
Okay, I feel better knowing you're here.
I'm here with you every step. Let me go grab your IV supplies and ondansetron. I'll be right back.
Scenario 3, patient presence after taking anticoagulants prior to procedure.
Mr. Daniels, good morning. I'm Nurse Kim, and I'll be preparing you for your colonoscopy today. How are you feeling this morning?
Good morning. I'm all right, I guess. A little nervous, to be honest. Never had one of these before.
That's totally normal. Most patients feel that way before their first colonoscopy. You're in good hands. We'll go step by step and make sure you're comfortable the entire time. Is it all right if I go through some questions with you before we start?
Sure, go ahead.
Great. First, have you had anything to eat or drink this morning?
Nope. I stopped eating after dinner last night around 7. Just had some water around 6 this morning, like the instructions said.
Perfect. That's exactly what we want. Now, I'll just review your medication list. Did you take any of your usual morning meds today?
Yes, I took all of them this morning: lisinopril, metoprolol, baby aspirin, and my Eliquis. I take them at the same time every day with a glass of water.
Okay, thank you for that. Just to confirm, you took both aspirin and Eliquis this morning?
Yes, that's what I always do. Is that a problem?
Thank you for sharing that. It's really important. Eliquis and aspirin are both blood thinners. For procedures like a colonoscopy, especially if a biopsy or polyp removal might be involved, we usually stop those medications in advance to reduce bleeding risk.
Wait, no one told me to stop them. Not my primary doctor, not the person who scheduled me. I thought I was just supposed to fast and take the PrEP.
That's understandable. It sounds like there may have been a gap in communication. Unfortunately, this happens sometimes. You've done nothing wrong. It's not your fault. Our job is to catch these things before the procedure starts.
So what does that mean now? Am I not going to have the procedure today?
I'll need to speak with the doctor right away to confirm the plan. But likely, we'll need to postpone the procedure and reschedule after your medications are safely held for a few days. Eliquis usually needs to be stopped at least 48 hours in advance. Continuing today could pose a bleeding risk.
This is so frustrating. I took time off work. I had to arrange care for my wife, who has dementia, and my son took off work to drive me here. All that for nothing?
I completely understand how frustrating this must feel, especially after all the effort you and your family made. Your disappointment is totally valid, but I want to assure you we're not wasting time. What we're doing now is just as important, making sure the procedure happens safely and at the right time.
I wish someone had explained all of this better. I would have stopped the meds if I'd known.
I hear you. We'll make sure that going forward, the instructions are very clear and written out for you. Let's work together to fix this. I'm going to step out briefly and speak to Dr. Rivera. Then I'll come back and walk you through the plan.
All right, I just want to get this over with, but safely, like you said.
Exactly. Back in a few minutes.
Nurse Kim steps aside to call Dr. Rivera using SBAR format.
Hi, Dr. Rivera. This is Nurse Kim in Pre-Op Bay 4. I'm calling about Mr. Robert Daniels, scheduled for colonoscopy this morning. Mr. Daniels took his regular morning medications today, including Eliquis 5 mg and aspirin 81 mg, roughly 2 hours ago. He is stable, no signs of bleeding or distress. Vitals normal. However, the presence of apixaban and aspirin significantly increases his risk of post-polypectomy bleeding. Recommend postponing the procedure and coordinating with his PCP or cardiologist regarding anticoagulant management. Would you like me to initiate rebooking?
Yes, thank you for catching that. Please cancel for today. He'll need to hold Eliquis for at least 48 hours, possibly 72 depending on cardiology input. Let's plan to reschedule early next week.
Understood. I'll update the patient and the chart. Mr. Daniels, I just spoke with Dr. Rivera. We've decided to postpone today's procedure for safety reasons. Because you've taken both aspirin and Eliquis this morning, it would not be safe to proceed.
All right, I figured that might happen.
Dr. Rivera recommends holding Eliquis for 48 to 72 hours before the next appointment. We'll also check in with your cardiologist to make sure that's appropriate based on your heart condition. Once we get that clearance, we'll reschedule.
I appreciate you explaining everything so clearly. I really didn't know.
Of course. You've been very cooperative. I'll also provide a detailed written checklist next time that includes what meds to stop, when to stop them, and who to call if you have questions.
That would help. I want to make sure we get it right next time.
And we will. Let's get this rescheduled so you can move forward with peace of mind. I'll bring the scheduler over shortly.
Scenario 4. Patient arrives wearing dentures prior to sedated colonoscopy.
Ms. Moore, good morning. I'm Nurse Kim, and I'll be helping get you ready for your colonoscopy today. How are you feeling?
Hi, nurse. I'm feeling all right, just a little jittery. I've never had this kind of test before.
Totally understandable. It's normal to feel that way. We're going to take everything one step at a time. You're not alone, and we'll be right here with you the whole way.
That's reassuring. Thank you.
Of course. Now, before we get started, I'd like to go over a quick checklist to make sure everything is safe for sedation. Have you removed all jewelry, eyeglasses, hearing aids, and dentures?
Oh dear, I completely forgot. I'm still wearing my dentures. I didn't even think about that.
That's okay. And thank you for letting me know. It's something that slips the mind for a lot of patients. Since this is a sedated colonoscopy, it's very important that we remove your dentures before the procedure.
Really? I didn't know that. I thought since it's not oral surgery, it wouldn't matter.
Great question. It's actually a safety issue. When you're under sedation, your jaw and throat muscles relax, which means your dentures can come loose. If that happens, they could block your airway or even slip into your throat. That's something we want to avoid at all costs.
Oh my, I had no idea. That sounds serious.
It can be. Even though it's rare, it's a risk we take very seriously. That's why we have protocols in place to remove anything that might obstruct your airway before we start sedation.
I understand, but I feel embarrassed without them. I don't like the idea of other people seeing me like that.
You're not alone in that. Many patients feel the same way. And I want you to know that we're here to keep your dignity intact. We handle everything with discretion. Your dentures will be carefully stored in a labeled container with your name, and no one will see you without them except the medical staff involved in your care.
All right, thank you. That helps a little.
Would you like some assistance removing them?
Yes, Please, I feel a bit shaky.
No problem at all. Let me just put on gloves and I'll assist you. Afterward, I'll label your denture cup and secure it in the storage bin we use for procedures.
Nurse Kim dons gloves and gently helps Ms. Moore remove her upper and lower dentures. They are placed in a labeled denture cup and sealed.
I feel strange without them. I hope I don't scare anyone.
You look just fine. And once the procedure is done and you're awake, we'll return them to you right away. You'll be back to normal in no time.
Thank you for being so kind about it. I was worried I'd be judged.
Never. You're doing everything right, and your safety comes first. I'll document this in your chart now, and then we'll continue getting you ready. You're doing great.
Scenario 5, missing informed consent and no accompanying guardian prior to sedated colonoscopy.
Mr. Lang, good morning. I'm Nurse Kim, and I'll be preparing you for your colonoscopy today. How are you feeling?
Hey there, nurse. I'm all right, just hoping this goes quickly so I can grab some lunch afterward.
I hear that a lot. You've already made it through the prep, and that's often the hardest part. Let's go through a few things before we get started.
Sure thing.
So, just to confirm, you're scheduled for a sedated colonoscopy this morning, correct?
Yes, that's right. They told me I'd be asleep during it.
That's correct. We'll be using a light sedative through an IV to keep you comfortable. Now, I just need to confirm that we have your informed consent on file.
Consent? Oh, no one gave me anything to sign. I just showed up like they told me to.
I see. It's essential that we have your written consent for sedation. It outlines the risks, benefits, and what to expect. Did anyone at the clinic or your referring doctor go over it with you?
Not really. They just gave me a prep kit and told me when to come in.
Okay. Thank you for letting me know. We'll take care of it now. Also, one more thing, since this is a sedated procedure, we need a responsible adult to accompany you home. Is someone here with you today?
Oh, actually, no, I took a cab here. I thought I could just take another one back after the test.
I totally get it, Mr. Lang. A lot of patients assume that, but it's hospital policy. And for your safety, that you don't leave alone after receiving sedation. The medication can impair your judgment, coordination, and reflexes for several hours, even if you feel awake.
Well, I didn't know that. I don't really have anyone to call on short notice.
That's okay. We'll talk through your options. For now, let's first go over the informed consent form together. I'll explain it in plain language, and you can let me know if you have any questions before you sign.
Yeah, that sounds good. I don't want to hold things up.
Not at all. We just want to make sure you understand everything. This form confirms that you know what the procedure involves, including the use of sedation, potential risks like bleeding or perforation, and that you can withdraw your consent at any time.
Understood. That all sounds reasonable.
Nurse Kim hands him the form and provides a pen. He signs it after reviewing.
Great. Now about your escort. Do you have any family or a neighbor you could call who might be able to pick you up later?
Maybe my neighbor Tony. He's retired and usually around.
Perfect. Why don't you give him a quick call? I can step outside to give you some privacy.
Thanks. I appreciate it.
A few minutes later.
All right, he said he can be here by 11:30.
That's perfect timing. I'll document him as your designated escort, and once he arrives, we can proceed with the sedation. Thank you for sorting that out.
No problem. I really had no idea about all this.
It's more common than you think. That's why we always double-check before moving forward. You're doing great.
Thanks, Nurse Kim. You've been really helpful.
Of course. I'll notify Dr. Patel now and update your chart. Let me know if you feel unwell or need anything the meantime.
Scenario 6, patient requests to stop procedure due to abdominal pain. Mid-procedure, Mrs. Young lying on her side, facial expression tightening.
Ow, oh no, it's hurting, it really hurts. Please, I can't do this anymore. Please stop.
Mrs. Jung, I hear you. You're in pain right now. Thank you for letting us know. Let's pause for a moment, okay? I'm going to tell the doctor right away.
Nurse Kim turning to the doctor.
Dr. Seo, the patient is experiencing significant abdominal pain and is asking to stop the procedure.
Understood. I'll withdraw the scope gradually and end the exam at the current level. Please keep the patient calm and monitor her vitals.
Mrs. Jung, we're stopping the exam now. Dr. Seo is carefully removing the scope, so just take some slow, deep breaths with me. You're doing really well, even if it doesn't feel like it right now.
I'm sorry, I must look ridiculous. I really thought I could handle it, but the pain was too much. I feel so embarrassed.
There's absolutely no need to feel embarrassed. Everyone has different pain thresholds. You did the right thing by speaking up. Your safety and comfort are our top priorities.
Do most people get this much pain? I feel like I failed.
Actually, it happens more than you'd think. Some patients don't feel much at all, while others feel cramping or sharp pressure. It depends on how your body responds. You didn't fail at anything. Listening to your body is something to be proud of.
Thank you. I was so nervous this morning, but I didn't want to seem like a burden.
You're not a burden. This is your body, your health, and you get to say what's okay and what isn't. Speaking up takes courage, and I'm glad you trusted us enough to do it.
That makes me feel a lot better.
Good. You're safe now. Once the scope is fully removed, we'll help you rest and give you some warm tea. If you're still sore afterward, we can also talk to the doctor about pain relief.
The scope has been fully withdrawn. We managed to view up to the sigmoid colon. Let's review the images afterward and discuss next steps.
Well done, Mrs. Jung. You did an amazing job, really. We'll continue monitoring your vital signs, and I'll stay right here with you while you recover.
I didn't expect to be treated with this much kindness. Thank you for not judging me.
That's what we're here for. Not just to perform procedures, but to care for people. You're never alone in this room.
Scenario 7, blood and stool after biopsy.
Mr. Daniels, you're now in the recovery room. The colonoscopy went as planned, and the doctor took 2 small biopsies from your colon. For the next couple of hours, we'll monitor your vitals and check for any unusual symptoms. You may feel some gas or bloating. That's normal after the procedure. It's important to let me know if you experience severe pain, dizziness, or notice any blood when you go to the restroom. Also, some light bleeding in your first bowel movement can happen after a biopsy. But if it's more than a few streaks, or if you're feeling lightheaded, please call me right away.
Nurse documents and chart.
Post-procedure baseline vitals stable. Patient alert and oriented. Biopsy sites monitored. Patient educated on post-procedure expectations and warning signs.
Nurse, there's blood in the toilet. It's red and looks like quite a bit. Is this supposed to happen?
Mr. Daniels, I'm right here. Don't worry. Let's take a look together and I'll assess the situation. Are you feeling dizzy or lightheaded?
A little bit, and my heart feels like it's racing.
I see. This is more than we typically expect after a biopsy. I'm going to help you back to the bed and check your vitals again, okay?
Reassessment of vital signs.
Possible post-polypectomy bleeding. Hemodynamic changes suggest borderline instability. Needs MD evaluation.
SBAR report to doctor.
Hello, Dr. Patel. This is Nurse Kim from the Endoscopy recovery room. I'm calling regarding Mr. Daniels in Bay 3. The patient is experiencing rectal bleeding after a colonoscopy with biopsy done about an hour ago. He is a 57-year-old male. 2 polyps were removed from the sigmoid colon during today's procedure. No prior history of bleeding disorders. He was stable post-op with normal vitals until now. He reported seeing a moderate amount of bright red blood in the toilet. On reassessment, his blood pressure dropped to 100/64, heart rate elevated to 102, and he's slightly pale and anxious. No syncope, but he reports mild dizziness. I recommend further evaluation. Should we prepare for IV fluids, labs including CBC and coagulation panel, and possibly notify GI on call?
Yes, start a normal saline bolus, 500 milliliters over 30 minutes. Order a stat, CBC, PT, APTT, and type and screen. Keep the patient NPO and monitor output. I'll come assess him in 10 minutes. If bleeding worsens, notify GI immediately.
Mr. Daniels, the doctor has been updated. We're going to give you IV fluids to support your blood pressure and run some blood tests to see what's going on. You'll be kept on NPO for now, meaning nothing to eat or drink.
Is it serious? Should I be worried?
I understand it's scary, but you did the right thing by letting us know quickly. Bleeding after biopsy can happen, and we're acting fast to make sure you stay safe. The doctor will be here shortly and will be with you every step of the way.
Nurse starts IV bolus, draws labs, labels and sends specimens, reassesses vitals every 15 minutes. Scenario 8, abdominal bloating and discomfort after procedure.
Mrs. Taylor, you're now in the recovery area. The colonoscopy is all done and you did great. There was no biopsy taken, just a complete inspection of the colon. Right now, we'll keep an eye on you and check your vitals regularly. You may feel some bloating or fullness in your abdomen. That's because we used air to expand the colon for better visibility during the procedure. The gas usually comes out naturally over time.
Baseline vital signs, nurse documents and chart.
Patient stable post-colonoscopy. No biopsy performed. Informed about expected post-procedure bloating. Monitoring in progress.
Nurse, my stomach feels so full and tight. It's kind of painful and I don't feel like I can move.
Mrs. Taylor, thank you for telling me. That bloated feeling can happen after the air used during the procedure stays in your colon. Let me check your abdomen and I'll help you feel more comfortable.
Nurse palpates abdomen gently.
I can feel some distension, but your belly is soft and there's no rigidity, which is a good sign. Your pain seems to be from trapped gas, which is common.
Clinical decision.
Assessment suggests post-procedure abdominal distension due to retained insufflated air. No acute signs of perforation or internal bleeding. I'm going to place a warm pack over your abdomen. That often helps relax the muscles and encourage gas movement. I'll also adjust the bed to help you stay in a semi-Fowler's position that can ease the pressure. Let's also try moving your legs slowly while in bed. Small movements can help get the gas moving. Once you feel a bit better, walking even just a few steps can really help relieve the pressure.
It hurts when I try to move.
I understand. Take your time. We'll go slowly and I'll stay right here. Let's start with just bending your knees and moving them side. I'll guide you through it.
Nurse assists with bed leg movements, applies warm bag over abdomen, reassesses discomfort level in 10 minutes. Reassessment of vital signs after 10 minutes.
You're doing great. The warm bag is working and your body is starting to respond. When you're ready, we'll help you take a few steps. That's usually the best way to help the gas pass. After a colonoscopy, this type of bloating is really common. The air we use has to come out the same way it went in through your body naturally. It's not dangerous, just uncomfortable. Moving helps a lot, and the warm compress is also very effective. If the pain gets sharp, or if you feel nauseated or dizzy, let me know immediately. That would be something we need to reassess quickly. But right now, everything looks within the expected range. Mrs. Taylor, let's try sitting you up slowly. I'll support you. Just let me know if anything feels too uncomfortable.
Okay, it's still a little tight, but I think I can try.
Nurse assists patient to edge of bed, holds gait belt, slowly assists in standing. Patient takes 3-4 steps, passes small amount of gas.
That actually helped a little. I was embarrassed, but thank you.
No need to be embarrassed at all. This happens every day. You're doing everything right. Let's walk just a bit more if you're up for it.
Scenario 9, failure to confirm diet order after endoscopy.
Mr. Lee, you're now back in your room. The upper endoscopy is complete. You were sedated lightly, so you might still feel a little drowsy. We're going to monitor you closely until you're fully awake. Just so you know, patients are typically kept NPO. That means nothing by mouth until the doctor reviews the images and confirms that it's safe to eat. So we'll wait for the official report before giving you anything.
Vital signs post-endoscopy.
Return to room at 10:45 a.m. Stable vitals. Light sedation. Awaiting post-endoscopy report. NPO status maintained.
Hey, Kim, I see Mr. Lee just came back from endoscopy. He looks more awake now. Is he allowed to eat?
Not yet. The doctor hasn't completed the image review. He's still marked NPO.
Got it. I'll keep that in mind.
1:30, error occurs.
Mr. Lee, you must be hungry. I brought you some porridge. Let's try a little, okay?
Oh, thank you. I am quite hungry.
Patient begins eating 2 to 3 spoonfuls in.
Mr. Lee, wait. Who gave you food?
I thought he was fine. He looked fully awake.
He's still NPO. There's no diet order yet. The endoscopy findings haven't been reviewed. Eating before that can be risky, especially with sedation. Let's stop him from eating more. You'll need to notify the doctor and document the incident. I'll check for any aspiration signs and reassess vitals.
Mr. Lee, I'm really sorry. We need to pause your meal. We'll explain everything. Please don't worry.
Reassessment of patient.
No signs of aspiration observed. Patient monitored. Incident reported to medical doctor.
Nurse calls Dr. Han.
Hello, Dr. Han. This is Nurse A from the recovery ward. I'm calling about Mr. Lee in room 6. The patient accidentally received porridge before a diet order was entered post-endoscopy. He had an upper GI endoscopy this morning with light sedation. As of now, image interpretation has not been documented, and no formal diet order was entered. He consumed about 3 spoonfuls before we stopped him. No signs of coughing, choking, or distress. Vitals remain stable. We are monitoring him closely. Do you want to issue a diet order now or continue NPO and observe?
Keep him NPO for now. Monitor for any signs of aspiration for the next hour. I'll review the images and enter a diet order if everything's fine.
Scenario 10, missing post-procedure nursing documentation. Post-endoscopy recovery, earlier in the day. Nurse A to Nurse Kim.
Mr. Johnson is awake now. He says he feels fine and wants to leave. His wife is here to pick him up.
Okay. Did you check his vitals and pain level? And make sure he urinated before discharge?
He said he feels okay. I think he'll be fine.
Let's double-check everything. Can you get his post-procedure vitals, assess for abdominal distension or pain, and check if he's steady on his feet? Then chart everything before he leaves.
Later that day, nurse manager review. Nurse manager to Nurse Kim.
Hey, Kim, we had a follow-up call from Mr. Johnson's wife. She said he felt dizzy after getting home and nearly fell in the bathroom. We checked the EMR, and there's no discharge note or post-procedure vitals documented.
That's odd. Nurse A handled that discharge. Let me talk to her.
Nurse Kim to Nurse A.
Hey, I heard from the manager that Mr. Johnson had a dizzy spell at home. I checked his chart. There's nothing documented after the procedure. No vitals, no discharge summary, nothing.
Oh no, I thought since he looked okay and wanted to go, it would be fine. I didn't realize I had to document everything.
I know you're still learning, but if it's not documented, it didn't happen, especially after a procedure. We have to assess vitals, LOC, pain, abdomen, and mobility before discharge. Even if the patient feels fine, we can't skip the assessment or the charting.
Clinical reflection.
No post-procedure vitals. No assessment of abdominal status, pain, gait. No documentation of discharge readiness. No written discharge summary. Potential risk. Unrecognized hypotension or delayed sedation effects.
Retrospective entry and incident reporting.
We'll need to create a late entry in the EMR to reflect what was done, and complete an incident report since. The documentation was incomplete at the time of discharge. Let's also notify the physician just in case.
Nurse Kim calls Dr. Evans.
Hello, Dr. Evans. This is Nurse Kim from the Endoscopy unit. I wanted to update you on Mr. Johnson, who was discharged earlier today. We received a report from his wife that he felt dizzy at home after discharge. He had a colonoscopy earlier today. Vitals appeared stable verbally, but post-procedure assessment was not documented in the chart. No known complications during the procedure. He experienced near syncope at home. No reported injury. Documentation was missed due to staff oversight. We've initiated an internal review and completed a late entry. No further action seems required now, but please let us know if you want any follow-up arranged.
Staff debrief and learning.
This is a learning moment, not a punishment. I've made mistakes too, but we can't rely on memory, especially when it comes to post-procedure care. What we observe, we write. What we didn't write might as well not exist. Let's go over the discharge checklist again together and make sure we don't miss these steps going forward.
Thank you. I understand now. I'll take responsibility and be more careful next time.
Endoscopy nursing, bronchoscopy care. Scenario 1. Patient arrives on procedure day after taking anticoagulant.
Good morning, Mr. Miller. I'm Nurse Kim, and I'll be helping you prepare for your bronchoscopy today. Have you had anything to eat or drink this morning?
No, I've been fasting since last night just like the nurse told me, but I did take all my medications.
Okay, that's good to know. Can you tell me which medications you took?
My usual heart pills and my blood thinner, warfarin 5 milligrams, same as always.
All right, thank you for letting me know. I just need to pause here and check something. Please wait a moment.
Chart review and realization of missed step. Nurse Kim reviews the chart. Medication history, warfarin 5 mg listed. No documentation of anticoagulant hold. INR result, not available. Pre-procedure checklist, no item for anticoagulant use or INR result confirmed.
There's no record of holding warfarin and no INR result. This should have been addressed before today.
Nurse Kim immediately alerts the charge nurse.
Nurse Taylor, we've got a problem. Mr. Miller is here for a bronchoscopy with possible biopsy. He took warfarin this morning. There's no INR, no hold order, and our checklist didn't catch it.
This should have been flagged during the initial scheduling. Let's notify the doctor now and initiate safety hold.
Nurse Kim calls Dr. Lee.
Hi, Dr. Lee. This is Nurse Kim from the bronchoscopy suite. I'm calling regarding Mr. Robert Miller, room 2. Mr. Miller is here for bronchoscopy but took warfarin this morning. 72-year-old male with atrial fibrillation, listed for diagnostic bronchoscopy with biopsy. Pre-checklist had no flag for anticoagulation. No INR result on file. Vitals stable, no signs of bleeding. Patient took warfarin 5 mg this morning. Risk of bleeding is high if we proceed. Request to cancel today's procedure, order INR, and reschedule once it's safe. Also recommend we update our checklist to include mandatory anticoagulant verification.
I agree. Cancel the procedure, draw INR now, and inform the family. Please escalate this issue to nursing management.
Mr. Miller, thank you for your patience. Unfortunately, because of the blood thinner you took this morning, we'll need to postpone today's test. For safety, we need to check how thin your blood is using a test called INR International Normalized Ratio.
Oh, nobody told me to stop taking warfarin. Isn't that something you would have told me?
You're absolutely right, and I'm very sorry about that. It should have been explained clearly before today. We're going to draw some blood now, and once the results are in, we'll reschedule safely. Your safety is our top priority.
Nurse Kim's reflection note.
This event highlighted a gap in our pre-procedure workflow. While it's routine to confirm NPO status, we failed to confirm anticoagulant management, which is critical before invasive procedures. The checklist did not prompt this check. and I didn't proactively ask about INR or hold instructions. Going forward, I will always confirm anticoagulant use in last dose. Check INR results at least 1 day before procedures. Push for revision of the bronchoscopy checklist to include anticoagulant use, INR within 48 hours, doctor's confirmation of hold order if applicable.
Scenario 2, delay in bronchoscopy due to missing ECG result.
Good morning, Mrs. Carter. I'm Nurse Kim, and I'll be getting you ready for your bronchoscopy today. Have you had anything to eat or drink since last night?
No, I've been fasting just like the nurse told me, but I am feeling a bit anxious.
That's completely understandable. I'll be right here with you the whole time. Let me just review your chart and double-check the last few test results before we begin.
Nurse Kim opens the electronic health record and begins checking the procedure checklist.
Vitals are good. Consent forms are signed. Wait, there's no ECG result uploaded. It says pending upload, but the checklist shows that ECG is required because of her history of atrial fibrillation and heart failure. Mrs. Carter, I just need to step away briefly to verify something. I'll be right back, okay?
Is something wrong?
Not necessarily. I just want to make sure we've gone through all the safety checks before we begin.
Nurse Kim approaches unit clerk Ms. Park.
Ms. Park, do you see an ECG result for Mrs. Evelyn Carter, bronchoscopy patient in room 4?
Let me check. It looks like the ECG was done this morning in the ward, but it hasn't been uploaded to the system yet.
We can't proceed without it. She has a history of atrial fibrillation and mild heart failure. Can you call the ward and request an urgent upload or fax?
Of course. I'll call them right away.
Nurse Kim reports to charge nurse.
The ECG was completed this morning but hasn't been uploaded yet. Dr. Lee's orders specify that ECG must be reviewed before sedation due to her cardiac history.
You made the right call. Let's hold the procedure until we have the official result. Patient safety comes first.
Nurse Kim calls Dr. Lee.
Hello, Dr. Lee. This is Nurse Kim from the bronchoscopy suite. I'm calling regarding Mrs. Evelyn Carter in room 4. Her ECG result isn't available in the electronic chart. She's a 79-year-old female with a history of atrial fibrillation and mild congestive heart failure. The ECG was performed this morning in the ward, but the result is not yet available in the system. Vitals are stable blood pressure, 13678 millimeters of mercury, heart rate 82 beats per minute, oxygen saturation 97% on room air. However, we don't have ECG confirmation to rule out arrhythmia or ischemia before administering sedation. Recommend holding the bronchoscopy until the ECG is available and reviewed. We will notify you once it's received.
Good. Please keep me posted once the ECG is uploaded.
Nurse Kim returns to the patient.
Thank you for waiting, Mrs. Carter. One of the heart tests we need to confirm before your procedure hasn't shown up in the system yet. Because of your heart condition, we need to verify everything carefully before giving any sedation. Mrs. Carter, I apologize for the delay, but it's important that we make sure your heart is stable before the procedure. When someone has an irregular heartbeat like atrial fibrillation or reduced heart function from heart failure, sedation can sometimes make the heart rhythm even more unstable, and it can also affect blood pressure and breathing in unexpected ways. The ECG was already completed earlier today, but it hasn't been entered into the system yet. To keep you safe, we need to review that ECG result before starting any sedation. Please bear with us just a little longer. We'll proceed with your procedure as soon as it's safe to do so.
I see, that makes sense. I'm okay to wait. Thank you for explaining.
Scenario 3, sedated bronchoscopy without an accompanying guardian.
Good morning, Mr. Bennett. I'm Nurse Kim, and I'll be helping you prepare for your bronchoscopy today. Did anyone accompany you to the hospital today?
Hi. No, I came alone. My wife had a doctor's appointment of her own, so I drove myself.
Okay, thank you for letting me know. Just to confirm, this procedure will be done under conscious sedation, and you'll need someone to escort you home afterward.
Oh, I didn't realize that. I thought I'd be fine to drive myself back after resting a bit.
Actually, because we'll be giving you a sedative, you won't be allowed to drive or take public transportation on your own after the procedure. Sedation can impair your reaction time and judgment for several hours, even if you feel alert.
I didn't think it would be that serious. So, does that mean I can't do the procedure today?
Not necessarily. We'll first check if someone can come pick you up. Let me speak with the team and see what options we have.
Nurse Kim speaks to receptionist Ms. Park.
Ms. Park, Mr. Bennett is scheduled for a sedated bronchoscopy but came in alone. Can you try contacting his emergency contact or family member to ask if someone is available to pick him up after the procedure?
Sure, I'll call the number listed for his wife.
Nurse Kim reports to charge nurse.
Mr. Bennett has no escort for after the procedure. I've asked reception to call his wife. If no one is available, we may need to delay or convert to a non-sedated option.
Okay, let Dr. Lee know. If needed, we'll reschedule or reassess sedation type.
Nurse Kim calls Dr. Lee.
Hello, Dr. Lee. This is Nurse Kim from the Bronchoscopy suite. I'm calling about Mr. Harold Bennett in Bay 3. Mr. Bennett arrived alone and is scheduled for bronchoscopy with sedation. He's a 68-year-old with chronic cough and suspected bronchial lesion. Sedation is planned, but no escort is available. He drove himself here. He appears well-oriented. Vital signs are stable, but per post-sedation policy, he cannot leave unaccompanied. Recommend delaying the procedure or proceeding only if an escort can be arranged. Do you want us to explore a non-sedated option if no one can come?
Yes, wait and see if someone can arrive within the hour. If not, we'll reschedule. Thanks for the heads up.
Nurse Kim returns to patient.
Mr. Bennett, I spoke with the doctor. Since you'll be sedated, you won't be safe to leave on your own. Even if you feel fine afterward, the medicine can stay in your system for several hours and affect your reflexes. We're trying to reach your wife now to see if she can come after her appointment. If that's not possible, we may need to reschedule your procedure.
Okay, that's frustrating, but I understand. I wish I had known this earlier.
I completely understand. We should have emphasized that during your scheduling call. We'll make sure to walk you through everything step by step next time.
Scenario 4, discovery of dentures just before sedation. Patient in procedure room, sedation prep begins.
All right, Ms. Lin, we've got you settled and the monitoring equipment is connected. We'll begin sedation in just a moment.
Okay, I'm ready.
As Nurse Kim begins final checks, she notices something unusual about the patient's mouth.
Ms. Lin, are you wearing dentures right now?
Yes, I forgot to take them out. Is that a problem?
Yes, it is a safety concern. Dentures must be removed before sedation because they can become loose and block your airway during the procedure. Let's pause here. We'll need to remove them before we can continue.
Oh no, I didn't know that. I thought it was okay to leave them in.
That's completely okay. Sometimes this gets overlooked. I'll help you take them out and store them safely.
Nurse Kim contacts charge nurse.
Nurse Taylor, Ms. Lin still had her upper denture in right before we started sedation. I caught it during final mouth check.
Good catch. This is exactly why the pre-sedation checklist exists. Was it marked as removed?
No, that field was blank on the checklist. I'll update it and review with the team later. Ms. Lin, I just wanted to explain again why removing dentures is important. During sedation, your protective reflexes slow down. If a denture comes loose, it can block your airway and cause serious breathing problems. You did the right thing by letting me know. It's our job to keep you safe, and I'm glad we caught it in time.
I understand now. Thank you for explaining it so clearly.
Scenario 5, suspicion of aspiration risk or wheezing during auscultation.
Good morning, Mr. Cho. I'm Nurse Kim, and I'll be preparing you for your bronchoscopy today. First, I'd like to ask you a few health questions before we start. Have you ever had any complications with previous procedures or breathing issues?
Yes, actually I had a bad experience about a year ago where I choked on food and ended up with aspiration pneumonia. Since then, I sometimes wheeze when lying down.
Thank you for telling me. That's important. Let me take a listen to your lungs.
Nurse Kim performs lung auscultation.
I'm hearing some wheezing on the right lower lobe. Do you feel short of breath right now?
No, not really. But I do get this sometimes when I lie flat.
Wheezing in a patient with prior aspiration, this could be high risk under sedation. I need to escalate this.
Nurse Kim calls Dr. Lee.
Hello, Dr. Lee. This is Nurse Kim from the Bronchoscopy suite. I'm calling about Mr. Daniel Cho, scheduled for bronchoscopy this morning. I noted wheezing during auscultation and a prior history of aspiration pneumonia. 70-year-old male with history of food aspiration last year and recurrent wheezing. Today's vitals are stable, but right lower lobe wheezing is present. Patient is not currently short of breath, but the wheeze and aspiration history pose a sedation risk. He may require aspiration precautions. Request evaluation before sedation. Suggest elevating head during procedure and standby suction ready. Consider steroid or bronchodilator premedication if appropriate.
Agreed. Let's proceed with aspiration precautions and elevate the head of bed. No sedation until I reassess.
Mr. Cho, thank you again for sharing your medical history. Based on what you told me and what I heard in your lungs, we'll take some extra precautions today to make sure everything is safe. We'll keep your head elevated and have suction equipment ready just in case. The doctor will assess you shortly before starting. If needed, we'll give you some medication to open your airways more.
Thank you. I'm glad you caught that before starting. I do get nervous about these things.
That's totally understandable. We'll keep a close eye on everything. You're in safe hands.
Scenario 6, observation of blood-tinged sputum after biopsy.
Mr. Han, we've completed the bronchoscopy with a small tissue biopsy. You're now in recovery. Just rest here while we monitor your vitals and breathing.
Okay, I feel a little bit of a tickle in my throat.
That's normal. If you need to cough, please use this tissue and let me know if you see anything unusual.
Mr. Han coughs. The sputum is slightly blood-tinged.
Nurse, there's blood in his spit. Is this normal? He's coughing up blood.
Thank you for calling me over. I understand this can look alarming, but slight blood in the sputum is very common after a biopsy. Let me take a closer look and assess.
She examines the sputum and begins a quick check of vital signs.
His vitals are stable and the amount of blood is very minimal. This is considered within the normal range after a bronchoscopy with biopsy.
Nurse Kim calls Dr. Lee.
Hello, Dr. Lee. This is Nurse Kim calling from the recovery area. I'd like to update you on Mr. Stephen Han. Post-biopsy, the patient expectorated a small amount of blood-tinged sputum. 66-year-old male underwent bronchoscopy with minor tissue biopsy. No prior bleeding disorders. Normal vitals throughout the procedure. Currently stable. Minimal hemoptysis noted, bright red streaks in mucus. No signs of active bleeding or distress. Vitals normal. We'll continue monitoring. No further action needed unless bleeding increases or vitals change.
Understood. Keep me posted if anything changes.
Mrs. Han, I spoke with the doctor, and I also want to reassure you this light bleeding is completely expected after a small tissue sample is taken. If the bleeding increases or if Mr. Han feels dizzy or short of breath, we'll respond right away. But right now, everything looks fine.
Thank you. I feel better knowing it's not serious.
You're very welcome. We'll continue to monitor him closely.
Scenario 7, acute dyspnea and desaturation after bronchoscopy.
Mr. Lim, the procedure is over. You're now in the recovery area. Let me know if you feel any discomfort while you're waking up.
I'm having trouble breathing.
Nurse Kim immediately checks pulse oximeter.
Oxygen saturation is 88% on room air. Sir, I can see you're struggling. Stay calm. I'm going to give you some oxygen now.
Nasal cannula attached at 3 liters per minute. No improvement. Escalates to non-rebreather mask at 10 liter per minute.
Let's raise the head of the bed. Try to take slow, deep breaths. I'm also going to check your airway and suction if needed.
Nurse Kim suctions oral secretions and confirms patency of airway. Nurse Kim calls Dr. Lee.
Hello, Dr. Lee. This is Nurse Kim in recovery. I'm calling about Mr. Paul Lim, who just finished his bronchoscopy. Post-procedure, the patient developed acute dyspnea with initial oxygen saturation of 88%. 73-year-old male with COPD. Sedated bronchoscopy completed 15 minutes ago. No intraprocedural complications. Patient was alert but in respiratory distress. Oxygen saturation rose to 92% with 10 lel-min via non-rebreather mask. Suction performed. Mild wheezing noted. Using accessory muscles. Request immediate physician assessment. Recommend continuous oxygen, possible bronchodilator nebulization, and chest X-ray if symptoms persist.
Understood. I'll be there in a minute. Keep monitoring closely.
Mr. Lim, we've started oxygen and it's already helping. I know this feels frightening, but you're doing well. Your oxygen level is coming back up. The doctor is on the way.
Still a little tight, but better than before.
Good. Keep breathing slowly and let me know if it worsens. We've got everything in place to take care of you.
Scenario 8. Patient develops low blood pressure and slow heart rate after sedation.
Mr. Kim, I just gave you a little bit of medicine to help you relax during the procedure. You might feel sleepy soon. Are you feeling okay?
Yes, but I feel a bit dizzy.
Let me check your vitals real quick.
Nurse checks blood pressure, heart rate, oxygen saturation.
Mr. Kim, can you hear me okay? Is it hard to breathe?
I feel lightheaded, like my heart is slowing down.
Nurse Kim reporting to the doctor.
Dr. Lee, after giving midazolam, Mr. Kim's blood pressure dropped to 76/42, and his heart rate is down to 42. I think it's a reaction to the sedative.
Okay, let's act fast. Is he on oxygen?
Yes, 2 liters by nasal cannula. Breathing on his own, oxygen saturation is 95%.
Let's give atropine 0.5 milligram IV and a 250 mmL saline bolus. We need to bring up his pressure.
Got it. I'll give atropine and start the bolus now.
Nurse Kim to Nurse Park.
Nurse Park, can you get a second bag of fluids ready? We may need more depending on how he responds. I'll monitor the ECG.
I'm on it. Let's put the cardiac leads on and watch the rhythm.
Nurse attaches ECG, shows bradycardia and a longer PR interval.
Mr. Kim, your heart is beating a little slow, so we're giving you medicine to help. Don't worry, we're right here with you and taking care of everything.
Thank you. I can still breathe, okay?
That's good to hear. Just rest. We'll make sure you're safe.
Scenario 9. Ongoing throat pain and dry cough after procedure.
Ms. Carter, you're in the recovery room now. The procedure is done. How are you feeling?
Breathing is okay, but my throat really hurts. And this dry cough won't stop. It's been over an hour already.
I understand, Ms. Carter. During the procedure, the scope passes through your throat and into your airways, so it's very common to feel some throat discomfort and coughing afterward. Are you having any trouble breathing? Have you noticed any blood in your phlegm?
No blood, and I can breathe fine. But this constant cough is making me tired.
That makes sense. What you're experiencing is a typical reaction. Your throat is likely just irritated from the scope. It usually gets better within a day. However, if your cough gets worse or you start feeling feverish or notice blood in your mucus, let us know right away. Let me check your vitals again, just to be safe.
Nurse Kim calls Dr. Lee.
Dr. Lee, Ms. Carter is now 1 hour post-procedure. She's reporting a sore throat and ongoing dry cough. No shortness of breath, no fever, no hemoptysis. Vitals are stable. I'll continue monitoring for now.
Thanks. If the cough worsens, consider giving a mild cough suppressant. For now, keep observing and reassure her.
Ms. Carter, your vitals look good. The cough and sore throat you're feeling are normal after this type of test. Try to sip warm water often, avoid spicy or rough foods today, and rest your voice if you can. That'll help your throat recover faster.
I was worried I caught a cold or something.
That's a totally understandable worry. But based on your symptoms and vitals, I think this is just part of the normal healing process. If anything changes, like you get a fever, chills, or chest pain, please press the call bell or tell us right away. Okay?
Scenario 10, incomplete documentation and missed handover information.
Mr. Lee, your procedure is all done. How are you feeling?
A little dizzy and tired. My chest feels kind of tight too.
Thank you for telling me. Let me check your vital signs again. His blood pressure and heart rate are a little low. He said he feels chest tightness. I'll watch him a bit longer. But I'll just take him to the ward now and tell the next nurse directly.
Nurse Kim gets called away and leaves with the patient without documenting the new symptoms or changes. Arrival at ward handover begins.
Hi, you must be Mr. Lee. Welcome back to the ward. How are you doing?
Still a bit dizzy. My chest still feels tight.
You're having chest tightness? Did that just start?
No, I told the nurse downstairs about it, right after the test.
That wasn't mentioned during handover. Let me quickly check your vitals again.
Nurse Taylor calls recovery room.
Hi, this is Taylor from the ward. I just received Mr. Lee, and he says he had chest tightness and dizziness after the procedure. His vitals are low. I didn't hear anything about that during handoff.
Oh, I did notice his blood pressure and heart rate were down, and he mentioned tightness, but I forgot to write it down. I'm so sorry. I'll update the record right now.
After rounds, discussing patient status at the nurse's station.
Nurse Taylor, how is Mr. Lee doing now?
His blood pressure is still low, and he continues to report chest tightness. He said the symptoms started in the recovery room, but they weren't mentioned during handoff and nothing was documented either. Current vitals: blood pressure 98/54, heart rate 52, oxygen saturation 94%.
Symptoms like dizziness and chest tightness can be early signs of cardiac issues. Let's order an EKG and some labs, CBC and cardiac enzymes. Please monitor his vitals hourly and keep him on bed rest. Set the bed alarm just in case and notify me if anything changes.
At the patient's bedside, Nurse Taylor explains to the patient.
Mr. Lee, we're going to do an EKG and some blood tests to check your heart. Please stay in bed and let us know right away if you feel any different. We're keeping a close eye on you.
Okay, thank you. I'm a little worried this might be serious.
I understand, but you're in good hands. We're monitoring everything closely and will respond quickly if needed.
Later that day, staff meeting with the charge nurse and team.
The situation with Mr. Lee today is a reminder that incomplete handoff communication can affect patient safety. When patients report symptoms like dizziness or chest, discomfort especially with abnormal vitals, it must be both documented and clearly communicated during handoff. Thankfully, the recovery nurse acknowledged the oversight and updated the chart. Still, moving forward, we'll reinforce our handoff checklist for recovery to ward transfers. Please make sure to follow it carefully. Patient safety depends on it.